I'm Mary Beth Landy. I am the Training, Support, and Recruitment Specialist for Western Mass for the Recruitment, Training, and Support Center for Special Education Surrogate Parents. And yes, it fits on my business card, surprisingly. I am hosting today's webinar, moderating it with a colleague, if you will, Dr. Rebecca Rosenblum, who I have asked to join us today. Based on her knowledge of trauma and EMDR, I think you get a lot out of this presentation. The information that's available will be available, the slides will be available to everyone after the presentation. If you have any questions, I would ask that you put them in either, let me just double check, the question and answer, Q&A at the bottom. If you have any technical questions or issues, you can put them in the chat box, which Yvonne will be looking at and moderating for me. This is being recorded, just so you're aware of that. And I think we are ready to begin. So, Dr. Rosenblum, would you like to take the floor?
Sure, thank you so much. And thank you for inviting me, and hello to everybody. This is interesting.
If you click on your presentation, you should be able to then use your up and down arrows to...
There we go, okay. So we're going to be talking about EMDR, which stands for eye movement desensitization and reprocessing. It's a form of therapy that was developed around 35 years ago by Dr. Francine Shapiro, who unfortunately passed away last year. This is an overview of the material we'll be covering. We're going to touch on common myths and understandings. I'm going to explain a little bit about trauma from an EMDR lens, what EMDR is, talk a little bit about disasters and the definition of disasters, introduce you to early EMDR interventions, which are a subset of the kinds of tools we use in the world of EMDR to address recent and ongoing stressors. Talk a little bit about the Boston Area Trauma Recovery Network, which I coordinate, and a little bit about social change and community well-being through EMDR interventions. And then just a little bit kind of bringing this all back around to how it might apply to your organization and the things that you do. So let's start with some common myths. These are myths that and misunderstandings that are held not just by lay people, but also by mental health professionals and even by people who have done basic training in EMDR but haven't stayed updated in the field. So a lot of people think that EMDR is only relevant for PTSD, or that it's only relevant for old experiences, old traumas in your past, or that it's only applicable for people who are neurotypical, or that it's only for people who have relatively quiet lives and are addressing something in their distant past. Some training organizations think that they can teach it in less than a weekend. Some people think it's a form of hypnosis, or that it doesn't do anything additional or special over what CBT or trauma-focused CBT offers. And some people don't think the eye movements matter, or the bilateral stimulation matters, or that it's not as effective as CBT, or that it's a new and untested treatment, or that it's not supported by rigorous research. So we'll come back around to those, and I'll sort of refute a lot of those during the course of my presentation. But let's start a little bit with a definition of trauma. So most people think about trauma and what makes something traumatic as being about the dramatic nature of the event. So something that is life-threatening or particularly violent, perhaps. And this impression of the definition of trauma really is encouraged by the criteria for the diagnosis of PTSD in the DSM system. But if you approach the issue from what happens in the nervous system when a person is highly stressed or traumatized, you can define trauma as something else, which is a concept that Judy Herman captured in 1992 when she talked about traumatic events as being extraordinary, not because they occur rarely or because they're dramatic, but because they overwhelm the regular and ordinary human adaptations to life. So in medicine, they use the same word, trauma, to encompass anything from a small tissue injury like a paper cut to a large injury like, say perhaps having a crush injury in an auto accident. And psychological trauma is an injury to the nervous system that occurs when the capacity of the nervous system to cope becomes overwhelmed, no matter how small or large the event seems to be. So adaptive information processing is the theory on which Francine Shapiro based EMDR and EMDR treatment. It's this idea that all human beings and most mammals are understood to have physiological-based information processing systems. In other words, our nervous system. And these information processing systems process the things that we go through, the experiences that we've been through in ways that are biochemical, and that they encode these memories, what we call memories, in an accessible and useful form. The memories are then linked together to other networks that contain similar thoughts or images or emotions or sensations or behaviors or impulses. And learning occurs when new associations are forged with material that's already in encoded memory. So it's like you're building on a foundation. When a traumatic or a very stressful event occurs, information processing can be incomplete. Maybe because there are strong negative feelings that are involved, or maybe because a person dissociates or checks out in order to get through the difficult experience. And these things interfere with information processing. And that interference prevents the forging of connections with adaptive or helpful information that is held in other parts of a person's memory network. To give you an example, somebody who might be a rape survivor might know that the rapist is responsible for the crime, but somehow this information in her own experience doesn't connect with her feeling that she's to blame for what happened. The sense that things are her fault might be something that she learned years or decades before, and in situations that have nothing to do with sexual assault. But a sexual assault memory then becomes dysfunctionally encoded because of this sort of network that's been laid down of how she may have been taught to think that all kinds of things are her fault. And then when she thinks about the trauma when the trauma is triggered by similar situations, she might feel like she's reliving it or might experience strong emotions and physical sensations that are connected with what she's been through. So things that might be experienced are things like intrusive thoughts or emotional disturbances, vivid sensory intrusions, negative self-referencing beliefs, all of the kinds of symptoms you would expect to see in PTSD. It's not only the major or big traumas, the kind of thing that the DSM system uses for a criterion event, that can cause psychological disturbance. A seemingly minor event from childhood or interactions that have been repeated throughout the years may not be adequately processed as well. In EMDR, in the world of EMDR, we refer to these as small t traumas, and they also can become the basis of dysfunctional reactions later in life. Dr. Shapiro proposed that EMDR therapy can successfully alleviate clinical complaints by reprocessing components of distressing memories. Reprocessing is thought to occur when the targeted memory is linked with adaptive information. Learning then takes place and the experience is re-encoded with appropriate emotions and able to adaptively guide the person in the future. So understanding trauma and EMDR through this learning-focused neurobiological perspective, we can see that EMDR is helpful in treating all instances of maladaptive learning, whether they're little t or big T traumas, whether they're chronic or acute, whether they're distant or recent or ongoing. In this perspective, people suffering with depression, addictions, eating disorders, psychoses, anxiety disorders, and many others can benefit from applications within the world of EMDR treatment and therapy. And this is what makes the AIP model, the Adaptive Information Processing Model, a meta theory, and makes EMDR a transdiagnostic treatment method. So in other words, all people have nervous systems, and thus all people can benefit from EMDR, regardless of diagnosis, age, developmental ability, neurotypical status, life circumstances, or resources. Though in many circumstances, specialized protocols or adaptations may be necessary. So EMDR is essentially an 8-phase treatment where you take a client history, you do a preparation phase where you explain and introduce the treatment to the person who's coming for that help. You assess the particular memory and awaken the different components of the memory and the nervous system. You then desensitize the memory over a course of bilateral stimulation and inviting the person to give associations about what is coming up as they remember things. You strengthen, or in our terminology, install a positive belief. You scan the body for any residual sense of upset or disturbance or negative feeling. And in between sessions, you always do a closure to help a person not dredge up what they were working on from session to session. And once you're done with a particular set of memories, you also always go back and check it out, reevaluate it, to make sure that things have really settled down rather than new material coming back up. In the world of EMDR, most of what most people think of as EMDR is actually the standard protocol. And EMDR therapy is a comprehensive approach for, as I mentioned, any of a number of diagnoses or symptom pictures with which a client may present. The goal is to reprocess or clear past targets or experiences that feed a client's triggered responses in the present, as well as rehearse future circumstances that might also trigger symptoms. So we talk about it as a 3-pronged approach because it deals with the past, the present, and the future. In addition to the standard protocol, there are many other developed protocols, both built around particular symptoms, like, for example, chronic pain, or other foci of therapy like attachment issues. EMDR therapy should be conducted by somebody who's completed basic training. Oops, sorry. In basic training in EMDR, or somebody who has achieved higher level of study. So, you complete basic training, which is 2-3-day weekends and several hours of consultation. And then some people go on to get certified in EMDR, which is a second step, a second layer of training. And then some people go on to become a consultant or a trainer. And each of those steps represents a different level of commitment and depth and experience to the treatment, the world of EMDR treatments. So let's switch for a moment and talk about disasters and disaster mental health. Dr. Shapiro first developed EMDR therapy around the effectiveness that it had in healing past traumas, things that were really in a person's distant past. But not long after that, she and her clients lived through a serious earthquake in the Bay Area. And she saw EMDR's applications for disaster response, as well as the need to adapt how EMDR was used or how she was using her protocol because of the way that recent memories behave differently from old memories. So before we get into disasters and EMDR though, let's talk about some terms. So disaster is actually a specific term that's defined by governments federally, within the United States, but also internationally. And it's defined as a potentially traumatic event that is collectively experienced. In other words, it can't be a private thing. It has an acute onset, and it's time delimited. So it's got a beginning, a middle, and an end. And it can be attributed to either natural causes, technological causes like transportation accidents, or for example, the nuclear reactor aspect of what happened with the earthquake and tidal wave in Fukushima, or human causes, which usually refers to episodes of mass violence. It's also defined in terms of the scope of what happens. So in order for something to be tagged or defined as an official disaster, 10 or more people need to be killed, or 100 or more people need to be affected. There needs to be often an international or perhaps a federal request for assistance, and a state of emergency needs to be declared. So these things are all components of the definition, because whether or not something meets this criteria determines whether or not, for example, FEMA is activated or the Red Cross is activated. So one of the reasons for getting involved in disaster community mental health is the capacity and opportunity to prevent or mitigate stress and trauma. So on the left-hand column, what you'll see is under prevention level, is that there are 3 levels of prevention that we're dealing with and addressing when we work with community mental health. We're dealing with primary prevention, which is preventing disorders from occurring at all, and this decreases incidence. We're dealing with secondary prevention, which is identifying disorders in their earliest possible stages and treating them, therefore decreasing the duration of the disorder. And then we're also dealing with tertiary prevention, which is reducing the degree of handicap or impairment and decreasing the impact that it has in a person's life over time. So on the right-hand column, what you see is the corresponding stages of early EMDR intervention for each of these areas. So the first piece is that we have stabilization procedures that we've developed, which are things that we teach people to do, either one-on-one or in a group situation. And these are tools that people can then use for themselves. They can sort of put them in their pocket and take them home, and use them whenever either the disaster in question continues to bother them or for anything else in their lives that is stressful. We also have protocols that we've developed that are developed around group administration. So it's not group therapy. These are interventions that we have where usually a large group of people, let's sort of imagine again, pre-COVID times when we would be meeting in person. You could have a large group of people in a conference room or a hotel room, and they're each working individually with a worksheet in front of them, drawing or expressing or writing graphically rather than talking out loud. So people aren't talking about upsetting things in a way that's going to trigger other people in the room. They're sort of doing their own one-on-one work that's being led by somebody in the front of the room with a team of support professionals. But they're doing their own private work to help move along whatever it is they've experienced. So it's a very confidential, private way of working. All the things that you see in parentheses and with abbreviations are just the names of the different protocols that we use in these situations. And all of these group protocols, we call them group protocols, but they can all be used one-on-one. And then we've got a deeper level of intervention that we can do, which are protocols that are based on working with somebody one-on-one, verbally, and really trying to get at the depth and root of whatever recent or ongoing experience they've had. So within the world of of EEI, which stands for Early EMDR Interventions. There's a whole suite of protocols, as you noticed from all of the acronyms, that we use with either current stressors, things that were recently experienced, things that are ongoing, or situations where there's no what we call a post-trauma safety period. Individual protocols are always administered by somebody with EMDR training who's gone through the basic training, but then also additional training in these protocols. Group protocols, as I explained, are these group administrations of individual work. They can theoretically be administered, or at least there are people on the team that can be allied professionals or paraprofessionals. But I'm sure, as you can all appreciate, in the US, that's a complicated issue because of issues around liability and professional kind of guild issues. So most of the work that's being done with exploring using EMDR, early intervention, with paraprofessionals has been done outside of this country and is being explored outside of this country. So these are actually really powerful interventions, and full symptom recovery can actually be attained in a very small period of time. So there's a lot of randomized clinical trials that have been done with these protocols. I think the number at this point of what's published is over 25. And in several of them, you get very similar results to this particular study, where you need 2 to 5 sessions for approximately 90% of the people treated to have most of their PTSD symptoms either completely cleared or at such a low level that they're really not bothersome. And these protocols are all applicable for traditional disasters like the kind we just defined, but also for chronic community stressors. So even though disasters have a very narrow specific definition, that doesn't mean that the tools that we use with disasters can't be applied more broadly. So earlier I talked about the idea of big T versus little t traumas, and you have sort of a parallel concept which I developed, which is the idea of big D versus little d disasters. So big D disasters are the traditional things that would meet a federal or an international definition. But then there are these unconventional chronic disasters that we can think of, like community violence or hate crimes or say COVID, right? That are still as responsive to the tools that we use for the traditional disasters. So there are some important ways that early EMDR interventions differ from the standard protocol or EMDR therapy. As I mentioned, they're very brief. Typically, they take 2 to 6 sessions. Here I'm talking about 90-minute sessions instead of 45-minute sessions. It would probably be longer with 45-minute sessions. They're not psychotherapy. You're not getting into a person's past. You're not doing a full evaluation. What you're really doing is a preventative treatment that's aimed at thwarting trauma from laying down roots. It's kind of like weeding seedlings versus like digging up a bush. They have a narrow focus, so we're really only focusing on whatever the event in question is. Let's say it's a car accident or a hurricane, or even if it's something ongoing, right? You're really only focusing on that thing. You're not getting into a person's past. And, you know, so you're not generally working with a person's past unless they specifically contract with you for something else. And we have all of these ways of modifying and altering the protocol so that you really minimize the extent to which something from a person's past might spontaneously come up in the work. It's because we're working often in disaster situations and we're working in a shorter time frame, the process for taking a person's history is much abbreviated. And as I mentioned, there are all of these tools that we use to build in containment, to build in resources, to allow a person to engage with what might be some very upsetting material without spending weeks and weeks and weeks preparing them to do that. So because of that, the therapists involved are typically much more actively engaged in the process than what you might see with regular EMDR psychotherapy, where the therapist is really encouraged to stay out of the way and just let whatever happens happen. And as I suggested before, early EMDR interventions can be part of a continuum of psychological aid, along with what's the traditional psychological first aid tools that people use, where our stabilization procedures can be seen as part of psychological first aid. And then the group interventions that I described, where you're working with a worksheet, can be seen as psychological secondary aid, and the individual deeper one-on-one versions would be viewed as psychological tertiary aid. So within the world of EMDR, there's an organization called Trauma Recovery EMDR Humanitarian Assistance Programs, and their website is emdrhap.org. And their main focus is to provide lower cost trainings of EMDR to people who work in the nonprofit sector. But they also are the home for a network of trauma recovery networks. So these are groups of EMDR trained professionals who are all volunteering their time both to run their own organizations and to donate clinical services. They're often not funded, so unless a particular organization has written a grant, they're just sort of operating all from volunteer time and in-kind donations. And the mission is to offer pro bono or free short-term early EMDR interventions after traditional disasters. Each group has their own identity, needs, and focus. There's a group in Arizona that is formed to cover the whole state. There are other groups that are much smaller that might be formed to cover a county or a metropolitan region. And TRNs, or trauma recovery networks, currently operate under the aegis of Trauma Recovery EMDR HAP, or Humanitarian Assistance Programs. Several of these groups have broken away from the parent organization, and they use the terminology of CRNs, or Community Response Networks, or TRTs for Trauma Response Teams. They all function basically with the same purpose, the same tools, and the same desire to mitigate suffering. People who work with trauma recovery networks under HAP have to have individual malpractice insurance. And the reason that I'm bringing this up is because a lot of the people who are clinicians of color or bilingual clinicians in a state or in an area are often working in clinics. And because they're working in clinics, they're covered by the malpractice insurance of their clinic. And they usually, because they're working in clinics, don't necessarily have the funds to buy their own malpractice insurance. So this means that the people who staff trauma recovery networks tend to pull from people in private practice, which also means that it tends to pull from an English-speaking, predominantly white group of clinicians. This is problematic because it results in the potential of an unintentional civil rights issue, because if you can't really serve all of the people within your catchment area because their language isn't spoken, or you struggle to provide services in that language, or because those populations aren't well represented in your treatment team, there's a potential that some of the most vulnerable people will go unassisted. So to give you a little history behind the Boston area TRN, which is the organization that I coordinate, The event that sort of started all of this was Hurricane Sandy in October 2012. A colleague of ours, Dave Dockstetter, organized a small team from Massachusetts. There were 7 of us. And we went down and got training in early EMDR interventions in January of 2013. And the protocol that we used was a protocol called RTEP, for Recent Traumatic Episode Protocol. And then from February of 2013 through April of 2013, 2 or 3 of us would go down to Staten Island every weekend and see people who had expressed a desire for services all day on Saturday. And we'd rotate in and out. And then what happened during that process is, as of course, as all of you know, the bombs went off at the Boston Marathon. And so we shut down our involvement in what was going on in terms of services in Staten Island and pivoted to setting up shop here in Massachusetts and working to address what had happened as a result of the Boston Marathon bombing. So just for people who like data and are curious about how that process went, this is a graph of the referrals that we received, that our organization received related to people who were having symptoms because of the marathon bombing. So as you can see, we launched pretty much immediately. And in the first year, which is represented by the darker gray, we had a few referrals in April right away. And that, of course, increased dramatically the next month as people got wind of who we were and our availability. But referrals were generally pretty steady through about January of the following year. Our process, our team, serves Eastern Massachusetts. During the marathon period, we had about 150 members at our peak. We fielded, all told, 90 referrals related to the Boston Marathon bombing. We sponsored 4 trainings, 4 trainings total, in early EMDR interventions for clinicians in the area. And we also, because of that issue that I described before of being a predominantly European extraction, English-speaking team, we sponsored partial scholarships to offset the cost of basic EMDR training for, it was about 8 to 10 clinicians of color. Since the marathon mobilization, we've been involved with a couple of faith-based groups, doing some work with them around issues that affected their congregations. And of course, right now we're mobilizing to address COVID-19 and the movement for Black lives. Before I go to the next slide, I just want to draw your attention to the graphs for March and April and even May in year 2. And so what you can see is around the time period of the first anniversary, there's an uptick in people asking for services, largely because a lot of people work really hard to tell themselves that they're doing okay and that they don't need help. And then as the anniversary comes around and the event is in the news all over again, they start having symptoms and they realize that, you know what, they're not really doing as well as they thought. And so oftentimes people come and request services more or less around a year later. So this graphic illustrates what could happen and what can happen over the long haul because of doing early EMDR interventions and disaster work. You know, you have a disaster that creates an opportunity. It creates an opportunity to work with people in the community that normally wouldn't come for therapy. And during the process of that, it also creates an opportunity for the team that's doing that work to examine and address gaps in how they're providing services. For us, part of it was about recognizing that our team was overwhelmingly white. And the importance of building relationships with colleagues serving underserved groups. So facilitating the training of those colleagues then puts EMDR-based tools in their hands, and then they treat their own communities, do their own work, create their own initiatives that really have the potential for creating some positive social change. So to bring this back around to the kinds of issues that your community and your audience might be addressing, just to sort of rephrase things from that perspective. So when EMDR started, it was focused on working with things that were in the distant past, things that were resolved in the sense of no longer becoming a threat, and what we used to call consolidated trauma. Which is sort of a way of describing something that might be like more neurologically entrenched. Then disaster response-based EMDR developed, and we developed ways of working with more recent or unconsolidated memories, things that had happened within 3 to 6 months, things that were perhaps not actually resolved but ongoing, and with a person whose neurological state is much more flexible. And then the more recent development, which is actually pretty recent over the last couple of years, is focusing on the idea that things are actually episodic and ongoing, that you can work with material that's not just recent, but you can work with a person's fears about what might happen in the future, right? So sometimes what stresses a person out most isn't what they've already experienced, it's what they imagine could still happen. And so you're working with people whose nervous systems are still feeling like they're under threat.
So Rebecca, actually, before you jump forward, would you just explain a little bit more about the neurologically entrenched versus flexible?
Sure. So when a person's had a recent experience, everything's right at the surface. They're usually feeling pretty raw. When a person's working with an old memory of something stressful, all of the coping skills that they've developed over the years that help them push awareness away or avoid dealing with it or minimize that it's not such a big deal, all of those things are really quite active. When something's happened recently, usually the system's so overwhelmed that, to use an old-fashioned term that I don't especially like very well, a person's defenses are down. And so a person isn't really defending quite so much against the idea that this bad thing just happened. And so that allows you to work with the nervous system in a much more direct way, because the feelings of anxiety or grief or hopelessness are much more accessible. They're not so packed away by whatever coping skills a person's developed over the years to get through their days. Is that cleared up? Thanks.
Yes.
Excellent question.
Thank you.
So taking all of that and thinking about the kinds of things that your organization addresses and seeks to mitigate or to help people with, there are different applications of the things that I've been talking about for your population. So when we think about early EMDR intervention and disaster work, we're thinking about external sources of stress, like a hurricane, like COVID, like violence against people of color. And those external sources of stress deplete people. They make it harder for a person to not be irritable or be patient with their kids. And so working with parents around those issues can increase the bandwidth for parents in their capacity to be patient. If you're talking about working with old material, you might be talking about using EMDR therapy to address being bullied, for example, and address that old history. But oftentimes there are experiences that we all have with parenting where we lose sight of the fact that our child is a child, and old buttons get pushed, and we respond in ways that really aren't about the current situation. And so using EMDR with old memories, old stressors or traumas, can increase a parent's capacity to remain grounded and flexible. Oftentimes there are in a parent's life ongoing conflicts with, say, partners that either you're still a partner with or that are past partners, that can let me put it this way. I'm sure everyone has had the experience of seeing in their child aspects of their partner or their former partner that they would perhaps prefer not to see. And so working with that material with EMDR and early EMDR interventions can help a parent sort of separate the child that's in front of them from the partner that they knew or know, so that they can respond to the child based on where the child is developmentally and who the child is, rather than kind of importing all the stuff with the partner and sort of sticking that onto the kid. And then finally, there are times when in a family system, maybe the person who's hurting the most isn't really willing to engage in doing their own work. And so using EMDR therapy or early EMDR interventions can provide an opportunity for the rest of the people in the family to have a clearer line of sight to what's within their control and feel less helpless and a greater sense of agency to cope with the situation. So most of the myths about EMDR that I outlined earlier, I think I pretty much covered by the presentation. There are just a couple that I haven't touched on. So one is this idea that you can learn it in less than a weekend. EMDR is a reasonably complex form of treatment, and it's extremely powerful, but it's also really important to learn it properly. There are different agencies, different training agencies that teach people how to learn EMDR. But if you have a therapist who learned EMDR in a weekend or less, you can probably feel pretty secure that they are not well trained. One of the organizations that's important, and maybe Mary Beth, you could put this in the chat for people, is EMDRIA, which is the EMDR International Association. And their website is emdria.org. And they have a section where you can see whether or not an organization has received their stamp of approval in terms of their training. And they also have a Find a Therapist section where you can see therapists who have gone through certification processes and met certain criteria in terms of their qualifications and their credentials in terms of doing EMDR therapy. There is a myth that goes around that says EMDR is just a form of hypnosis, but there is in fact neuroimaging research that shows that what happens in a person's brain when they're hypnotized is very different than what happens when a person is undergoing EMDR. And there are those who like to say that EMDR isn't really supported by rigorous research, but that also is not true at this point in time. There are many, many, many randomized clinical trials and rigorous research about all kinds of protocols and forms of EMDR and applications with different populations and different situations. If any of you are interested in reading more about EMDR from a book that's really sort of suited for the general public, Getting Past Your Past is a book that Francine Shapiro wrote and published a few years ago, and the first half talks about EMDR and it talks about tools from EMDR therapy that people can use for themselves to help cope with the stresses that happen in their lives. And that is it. Thank you so much.
Thank you, Rebecca. So there's a couple of questions or points that I had coming up. You talked a little bit about the post-trauma safety period. Could you explain a little bit more about that?
Sure. So if I suffered a really traumatic motor vehicle accident when I was 5, I don't know, maybe even like one of these things that like is the stuff of Hollywood movies, you know, one of my parents get killed or both of my parents get killed, or I don't know. That's, and I'm now 30 or 40 or 50 or something like that. That's something that happened in the past, and it's not an ongoing experience. It's something that happened, it had a beginning, a middle, and an end. It's a sort of acute trauma. Let's assume that that I didn't suffer any kind of medical or physical ongoing ailment because of the motor vehicle accident. So if I'm triggered today by certain sounds related to motor vehicle accidents, screeching brakes maybe, and I get flashbacks or other vivid imagery, when I hear that, what's happening in my nervous system is that more or less, I might be going around feeling generally safe most of the time, but then something happens in my environment that triggers me, and I get this sort of flood of reactions. So that's somebody who has a post-trauma safety period. Somebody who doesn't have a post-trauma safety period might be somebody who's in a situation with domestic violence. It might be somebody who did military service and comes back and becomes a firefighter. And so, you know, they spent however many years in the military with their nervous system being on red alert. And now they're a firefighter, and so their nervous system is still kind of on red alert because they're always prepping for the next situation that's highly dangerous, where their life may be at risk. So those are like a couple of examples of people that physiologically might not have the experience of a post-trauma safety period. And so we would adapt how we use the standard protocol or how we use early EMDR interventions with them.
Okay, would that be the same as, I know that we've talked in the past about some of the first responders in Boston Marathon bombing and them seeking services through the Trauma Recovery Network, that they are having to, because of their job, stay in that high vulnerable situation?
Yeah, so that's that is definitely part of it. The other part of it is like often, whether we're talking about a population like that has a lot of demands for a certain version of professionalism, you know, where outwardly they have to appear like they've got it all under control. You know, you could say the same, for example, for a lot of people who experience domestic violence and their parents, right? You know, there's this sort of like constant inner tension between having something that's really upsetting going on and, you know, having your nervous system kind of be on alert all the time, but being in situations where you can't really talk about what's going on, or you can't really show people that you're hurting, or you can't really show people that you're on edge, right? You know, you need to project a certain image outside to the world, or you feel like you have to. And that causes all kinds of complicated difficult, confusing reactions inside a person's system. So.
Okay. I think a lot of people and a lot of people at the Federation are hearing from parents a concern about returning to school in the fall. Not only what will that look like, but the mental health of the children who have been through the whole COVID experience, and concerns about how they will respond to things such as the experience of seeing everybody in masks, of all their classmates, things like that. Could you talk a little bit about EMDR in terms of a response to the COVID-19?
Sure. So, you know, the kind of obvious piece is using early EMDR interventions with medical, hospital staff, frontline workers who have had to deal with quite stressful situations that they're immersed in. There are, of course, all kinds of other people that follow in similar categories, like funeral directors, essential workers that have been in situations where they felt like their lives were put at risk, and in many situations where their lives were put at risk, but without any sort of, seemingly without any choice to do anything different. In terms of the issue with kids in schools, could you narrow down what it is you're wondering about or thinking of?
I think that one of the big situations that parents are concerned about is that they've had periods of disconnection, and that particularly for kids with special needs has been a trauma in itself, that they've been disconnected from their teachers, from what we would consider, you know, trusted adults, trusted classmates, and now they're going back to this very unknown situation, in one in which it's hard to do any preparation with them, because nobody quite knows what it's going to look like or how long it's going to last, or
Sure.
there are none of those answers. And I think that particularly for kids with trauma histories, which we deal with a lot of, that's very difficult for them not to be able to discuss and process with them about what they might expect coming, you know, in the future. And someone does, in one of the questions prior to that people filled out as part of the survey, was talking about how effective it is with children. EMDR.
Yeah, I mean, EMDR is there's, so I myself work with adults only, but I have colleagues who work with kids, and there are all kinds of sort of amazing and creative ways that people have adapted EMDR to work with kids, even fairly young kids. I think probably, though, the most useful response to your question isn't so much about EMDR therapy, but rather like the way that we see trauma in the nervous system, and how that informs how we do EMDR therapy. So the problem with stress and difficult situations is that people have a very understandable desire, impulse, reflex to push things away and avoid them. Mm-hmm. And feelings have their own, feelings are like waves, right? They have their own normal curve. They peak and subside. Even if you think about somebody who's really upset and going through a sobbing fit, right? You know, there are waves in that. You know, if you think of you know, like a child between the ages of 2 and 4 who's had something upsetting happen and they're sobbing about it, right? Like there are waves, you know, like there's like really intense wave and then it starts to come down and then they get upset again and then it comes down and maybe there's some more and, you know, but eventually it quiets down. And if we can help create a space where people can have their feelings, where children can have their feelings, and we don't tell them to, you know, have a stiff upper lip about it, and we don't tell them to put it aside, and we encourage them to express it through drawing or talking or you know, playing with their dolls or, you know, whatever it is. Years ago when my kid was a toddler, I went to motorcycle school for a weekend. And there was too much of a gap. I was gonna, you know, this was like when motor scooters were all the rage. And I was gonna, you know, learn how to drive something like a Vespa so that I could have a more environmentally conscious commute. But I had too much of a gap between my motorcycle school training and when I actually got out on the machine that I was going to try to drive. And so I had a crash. And it was a very mild crash, but unfortunately my kid saw me. And, you know, that afternoon we got back home and my kid had one of those pedalless bikes, you know, that you just sit on and they move with their feet. And what they did is they like mimicked my crash over and over.
Mm.
Took about, I don't know, something like 3 to 6 versions, right? Where they pretended that they were me crashing into the hedges. And then that was it. They never really gave it a second thought after that. So we have these natural processes that help us move through difficult experiences. But unfortunately, we also have this tendency to avoid letting ourselves go there. You know, whether it's, you know, being on Facebook or drinking or, you know, doing other things to kind of numb ourselves or check out or avoid the feelings that we're having. And if you can just sort of find a way to trust that your own feelings will come in waves and peak and subside and eventually quiet down, and that your children's feelings will also come in waves and peak and subside and eventually quiet down, then the trauma never takes root. The upsetting, stressful thing never takes root.
Okay. Someone's asking about working with children with reactive attachment disorder. How prevalent is it? And are there clinicians that you know of in Massachusetts that are trained to work with kids?
There are definitely clinicians trained to work with kids. EMDR is helpful. As I said, I don't work with kids myself, but I know enough to know that reactive attachment disorder is really complicated. And so I don't quite feel competent enough to answer that question.
Okay.
I just know that that's like one of the harder things to deal with. But I know of EMDR therapists who do a lot of training of other EMDR therapists who work with kids who would definitely have an answer for that question.
Okay.
So I'm sure there are people who do it. I don't know if there are people who do it in Massachusetts, and I don't know what it looks like.
Okay. The last question that I'll ask is really how to help children with this type of trauma who are re-triggered as they go back to school with possibly having a teacher or a peer falling ill because of COVID-19.
Yeah, so I think that's a really important question because we're not done with this. And as you might guess, I'm not one for avoiding looking something in the face. So this fall and this winter are going to be hard. And that's a completely reasonable scenario to wonder about. That, you know, let's say if kids, you know, go back to school, whether it's online or in person in some creative way, and then a teacher gets sick, or a fellow classmate gets sick, those are the kinds of things that could happen. And as grown-ups, as parents, we don't want our children to hurt, but the world's a hard place. And so I think developing some way to accept that difficult things can happen, and that people are going to have feelings about them, and that it's okay to have feelings about them, and that there are all kinds of tools we can use to work through our feelings about the difficult things that happen in life. Again, I don't work with children myself, so I can't be more specific about it than that. But I think as a general philosophy or mindset, if you can, most days, most of the time, keep that in mind, and invite the kids to find ways to express how they're feeling, and try not to shut it down, and try not to judge the feelings that are coming up, or you know, that they're emoting, or that they have this feeling or that feeling. I think that's probably the best most of us can do.
Great. Rebecca, thank you. I really appreciate you coming on.
Welcome.
Thank you for finally saying yes. I've been
It's all timing. It's all timing.
I get that. So, and now that we are forced to do things by Zoom, it makes it a little bit easier for clinicians to be part of it.
It does.
I'd like to thank everyone for joining us today, and remind you that the Federation is still open and taking calls. You can contact our call center. If you're a special education surrogate parent, you can contact RTSC, reach out to us, and we'd be happy to help. Do that either through phone call or email, and reach one of the training and support specialists. We'd be happy to do that. If you are not a special education surrogate parent and are looking for something to get involved in ways to help children who experience trauma, consider becoming a special education surrogate parent. You can do so at RTSC at fcsn.org. Yvonne has just put it in the chat. Again, Rebecca, thank you for being here. Everyone, thank you for your time today, and we look forward to seeing you next time.